So our next speaker is going to be Dr. Vibhu Mohanty of USF, and he's going to be speaking on neurocardiology, modern cardiac interventions for stroke prevention.
Thank you for having me. As you all know, I'm a cardiologist dealing primarily with structural heart disease, and I thank you all for inviting me to your meeting to share some of the things that we're working on in the neurocardiac space, which is really a rapidly developing and new arena that has been born of some very good collaboration between neurologists and cardiologists. And we're finding that there's lots that we can learn from each other to help patients who have ongoing issues after their acute stroke management with considerable overlap between the two disciplines. Those are my disclosures. This is just a brief outline of what I'd like to share. We'll start with a discussion on where this discipline has emerged from, which has largely been driven by regulatory processes that are essentially mandating collaboration between both disciplines, which is actually fantastic and is likely to be something we'll see more so in the future. We'll share a brief a bit about the collaborative model we've developed at our institution, and then we'll talk about two of the primary arenas that we have focused on, which is left atrial appendage closure and patent foraminal valley closure. So this is just a brief slide on what a typical regulatory process looks like, going from major randomized clinical trials through to device approval, followed by CMS approval and a means of reimbursement. So typically there's a major randomized controlled trial published or a series of them. This then leads to FDA approval, and then that's followed by CMS, typically defining national coverage decisions, which are then often published and adopted by insurance companies. The interesting thing about this is that the guideline directives from professional societies often don't tend to follow suit. They can be before, after, or really at any phase during this process. So it's kind of interesting to see some of the discrepancy between the two. The case in point that we have is for PFO closure. So this was relatively recent. After decades of study, the New England Journal published the long-term data from the RESPECT trial, which had been heavily anticipated for years, in 2016. As is commonly the case with many of our industry partners this day and age, this was done with considerable partnership through the FDA, just to make sure that things don't have to be repeated, and that trial data and documentation is in adherence to FDA policies, which often expedites approval. So that led to FDA approval actually simultaneously, basically the same day the study was presented at one of our major meetings, TCT. And then a few months thereafter, the CMS and insurance companies published policies guiding reimbursement for PFO closure. And then the interesting thing about that was that they mandated for the first time that patients who are closed by cardiologists have to be evaluated by a neurologist who has to approve that closure beforehand. So this was really a robust change in how things had been managed in the past, and for all intents and purposes, made it really important that we collaborate so that these patients can get a streamlined a pathway from stroke through diagnosis of cryptogenic stroke, confirmation of that, all the way through to PFO closure, and that they get a unified sense of direction from all parties involved. Then we have this issue of shared decision-making, which is also something that's recently been touted heavily by the FDA and by CMS. And that is that patients should be engaged and actively drawn into participation for their healthcare decisions. This is something that I think many of us consider we do. In fact, all of us do to some degree, certainly in the follow-up and outpatient setting, maybe less so in the emergent setting. But it's a topic that will come up more and more in future guidelines and future regulatory decisions that are given by FDA and other governing bodies. And for the purpose of this talk, for the Watchman device, which is the one device that's approved for left atrial appendage closure in this country, it requires in the documentation within the medical record, which I'll show you in a little bit, that this shared decision-making is performed using evidence-based decision aid, which is very specific, and it must be done by a provider that is not the implanting provider. So if a patient comes to me and says, hey, I've heard about this therapy for stroke prevention, left atrial appendage closure, what can you tell me about it? I can tell them all about it, but I can't do anything about it because they have to go back and get that documentation performed by someone who doesn't implant it. It's a little cumbersome and challenging, but again, it behooves us to develop programs that are collaborative to facilitate that process. And the intent of this is appropriate. We want to make sure that patients really understand what they're getting, why they're getting it, and why we're recommending it. And bringing them into the therapeutic discussion really helps them align their long-term goals and their habits as well. Over to the left there, you have a slide, and this is from 2011, and all that's showing is the number of articles or publications published on shared decision-making. And you can see, stemming from the 90s up into the early 2010s, there's been this rapid rise in interest in this topic from an academic standpoint, and there's probably a whole host of articles that have been published since. So it's something we're going to see more and more of, so it makes sense that we align with this methodology and thinking and partner to facilitate patient care. This is just a little further elaboration on that topic. Collaboration, as we all know, is the name of the game. In cardiology, the heart team approach, which involves cardiovascular specialists, interventionalists, and cardiac surgeons, is now uniformly a Class 1 recommendation in all of our guidelines. And so we're essentially extending from that. And again, from the FDA and CMS standpoint, a lot of this has to do with sustainability. We want to make sure that we're funding and propagating therapies that will not just treat a patient or treat something that we can do because we can do it, but actually lead to long-term health outcomes that are sustainable for both the individual and our society in general. So this is our neurocardiac program at our institution at USF. We have a partnership with neurology, with our cardiology department, and with our hospital and our procedures. And this involves clinics, it involves inpatient and outpatient consultation. There are EMR pathways and order sets that help organize all these things that are funneled to our providers and our program coordinator. We have clinical trials, we do outreach, education, and we have protocols for these three avenues, which are left atrial appendage closure, both surgical and percutaneous, PFO closure, as well as ambulatory monitoring, which is a really important part of this collaborative effort, largely for the diagnosis of atrial fibrillation. This is just a slide I like to put of what we like to think of ourselves as. You know, a lot of these patients, they go through the hospital, they're taken great care of in the acute setting, then they're discharged and they oftentimes don't know where to go. They are seen by neurologists, they're seen by cardiologists individually, they might be seen by physical therapists, other specialists, but they don't have a centralized place where they can go and actually have follow-up care to institute some of these therapies. So we like to think of ourselves as a safety net for these patients and capture their care pathways as an inpatient and then have them funneled directly through the outpatient setting so that they're not lost to follow-up. And again, these are our three primary pathways, and we'll be talking about the two on the sides, left atrial appendage closure and PFO closure. So let's start with LAAC, left atrial appendage closure. And again, the only device approved currently in the US is the Watchman device. There's an image of it there. You all know about the left atrial appendage. It's a remnant structure that has a lot of corrugated edges and ridges and grooves, a lot of pectinate muscles that can harbor clot. And we believe that 90 to 95% of thrombi that come from atrial fibrillation and result in stroke are harbored in the left atrial appendage. And so the way we describe it to patients is that it's a stroke prevention mechanism. The difference is that it's non-pharmacologic, unlike the predominance of our other options, which are NOACs or warfarin or various other drugs. These are some devices that have been used or are being developed worldwide. The Watchman device is there at the bottom. There are a host of surgical devices, the AtriClip devices at the top. There's also been the Lariat device, which was used several years ago to some degree, but has fallen out of favor. And then there's the Amulet device at the bottom, which is actually used fairly widely in Europe and is thought to likely make its appearance in the US in the next year or two, which will be good. It'll allow us for a little more variability, both to test our theories and to compare devices and have options for improvement. This is what the current Watchman device looks like. Comes in several different sizes as are listed there. Many of the appendages that we tackle can fit one of these sizes. I tend to tell patients anywhere about 95% of patients can be fit to one of these sizes. The device is squeezed into the appendage, so it does not have to be exactly sized. In fact, for an appendage, say that's 20 millimeters in diameter, we will often use a 27 millimeter device to make sure it's well sealed and well anchored. This particular device is a nitinol frame, has 10 anchors, has a fibrous coat on top that allows for endothelialization. This is a PT fabric material that's 160 microns thick. And then the anchors below are squeezed to allow it to adhere to the wall of the left atrial appendage. There is a device that will be coming out shortly by the same company, which will be quite an improvement on this device. It is not out on the market yet, but it'll be a shorter device. This device is essentially a square. It'll be a shorter device, and it'll have the end of it will be joined in a ball-like shape, so thereby essentially making it atraumatic. So we're very excited about that. But this is the current device that's out on the market. So the question is, why do we need a device like this? So here's this first slide I'd like to show. So this is from the NCDR registry in 2016. And what this shows is, we thought that the standard of care was oral anticoagulation, and that was what was projected for years. Here you see on this slide that warfarin is the dark blue at the bottom, and that is the number of patients receiving warfarin, and then as you go to the right, it's a CHADS-VASc score. So you can see that with warfarin alone, there's probably at most about 45% of patients who are actually receiving anticoagulation using that drug. If then you add the DOACs, which a lot of people thought would be the saving grace in this arena, you still get just below 60% of patients being treated with anticoagulation. And so this notion of standard of care is really sort of challenged by this graph when considering oral anticoagulants as the primary option. So it tells us there's a big treatment gap in patients who are treated with nothing or with just aspirin, which we know is not effective, or with combination aspirin and P2Y12 inhibitors, which we know are also not as effective in reducing stroke rates. So it tells us there's a huge gap in the number of patients who are not getting protected from stroke and whom we could address. And this is showing the Has blood score in conjunction with the CHADS-VASc score. So what this essentially says is, as you go to higher levels of stroke risk, as defined by CHADS-VASc, you also go to higher levels of bleeding risk. So it's part of the reason why, if we go back to this graph, why you see that the number of patients who are actually on oral anticoagulation tends to flatten in the middle and then actually take a little dip as you go to higher bleeding risk or higher stroke risk patients. And that's because the bleeding risk goes up. And so patients are less inclined or less willing to take anticoagulants in that setting. So again, further suggestion that there's something more that we need to do as providers to help protect these patients from stroke. When the DOACs came around several years ago, a lot of people thought, well, this is great. We don't have to follow these drugs. Levels don't have to be checked. The bleeding risk is far lower, and patients will probably take them more. But what this graph shows is 2 years out, 30% of patients who were started on DOACs had stopped taking them. And so there's an adherence issue, which we all know occurs with patients in any realm, in any subdiscipline. And so part of our goal then is to say, how can we make stroke prevention more efficacious, safer, and something that patients can tolerate more easily with regards to adherence? And so these are data from the PROTECT AF trial, which was the initial trial done for the Watchman device. And what I'm showing here specifically is 5-year data. This trial was started in the mid 2000s, there's a whole history behind it. The FDA came back to the company and the investigators and asked that they do a second trial, the Prevail Trial, which I'll show in a second, with a number of improvements on the design, on operator training, which was a huge part of the success of this device. And the two trials in combination are what ultimately led to approval. But this was the initial trial, which had a number of faults. And you can see that over the 5-year period of follow-up, the ischemic stroke rates were comparable, no difference, but cardiovascular mortality and all-cause mortality were significantly better with the device. And this probably speaks in large part to the bleeding risk. Obviously, as you are on anticoagulants for a longer period of time, there tends to be an accrual of bleeding events, hospitalizations, associated morbidity, all things that we know and recognize. And so that's probably what led to this statistical set of graphs, or this set of graphs with the statistics that are shown, showing changes in mortality from cardiovascular and all-cause and a similar ischemic stroke rate. This next graph is a forest plot of the PROTECT and Prevail trials together. So again, I just described the Prevail trial as what the FDA requested of the investigators and the company to get a better, tighter sense of what the outcomes truly looked like. And I'd like to point out a couple of important things here. So certainly with the device, there is a significant improvement in bleeding events, and that is usually what we're most worried about in terms of acute stroke, acute hemorrhagic stroke. So significant difference in hemorrhagic events, significant difference in disabling fatal strokes, near equivalence in stroke altogether, and then all-cause death and major bleeding events favoring the device itself. And this was, in both of these trials, warfarin was the drug that was used for the medical treatment arm. And then you can see at the very top, the all stroke and adverse events met basically cross unity, showing that, yes, there is equivalence. Oral anticoagulation is a great therapy for stroke prevention, about equal to the Watchman device, but there's significant reduction in bleeding events and therefore likely significant reductions in morbidity that led to a difference in all-cause death and major bleeding. And this is just showing what that bleeding difference actually is. So beyond the 6-month time point, the thought is that there's anywhere from 70 to beyond % reduction in bleeding risk with the device compared to medical therapy. This is some data that was actually presented just a few weeks ago. You can see the reference at our American College of Cardiology meeting, actually just about a month ago, showing some of the evolution of this therapy in various registries. So to the far left, you have the PROTECT AF, the initial study, and this is looking at procedural success, which is defined as implantation with no significant residual leak. Leak is defined as less than 5 millimeters of Doppler Doppler flow on TEE, transesophageal echocardiography. So you can see in the PROTECT trial, there was a 10% unsuccessful implant rate, which is obviously very high. Many of those implanters were new implanters. Many of them were not trained in transeptal puncture. They were using what would today be considered fairly archaic methods, going on with giant sheaths without any sort of guiding catheters. So there were a lot of issues that led to adverse events and poor success in that early experience. And then you can see the subsequent trials and registries. Prevail is in the middle, 95% success. Evolution is the European registry, where they actually do not use much anticoagulation after the device is placed, with a 98% success rate. And then what you have to the far right is the current US experience, 98.3% success rate. And a lot of this has to do with training, people becoming familiar, developing programs that help facilitate both preparation of the room, preparation of devices, preparation of materials that have allowed for a significant improvement in implantation success. These are some of the, again, from this recent registry data, complications, which are actually fairly good. When we compare other procedures that require transeptal puncture and manipulation of catheters within the left atrium, which tends to be fairly thrombogenic, things like left atrial fibrillation ablation procedures, these numbers are comparable, or many would say far better. And again, a lot of these were the result of early experiences by new providers who are still learning this procedure. I don't think I have this data, but the vast majority of implanters of Watchman in the country today have done 20 procedures or less. So a lot of early experience, but it has been shown that as patients or as providers become more experienced, these numbers fall drastically. And the primary thing that we worry about is pericardial effusion, particularly during the time that we are traversing the atrial septum, and then when manipulating within the left atrial appendage itself. And a number of procedural modifications have been made that make that much safer than when they first started using this device. These are the cumulative procedures since 2016, from when this registry was initiated. So certainly a considerable rise. And then I'd like to show you the process of Watchman. We talked about a little earlier this shared decision-making concept that is required for patients to have this therapy performed. And this is what that looks like, and I'll just list it all out here, before they're allowed to see someone like myself who actually does these. They have to have a CHA2DS2-VASc score of greater than 3, equal to or greater than 3. They have to, in the medical record, have an appropriate rationale to seek a non-pharmacologic stroke prevention alternative. And that could be anything. Appropriate rationale could be, I'm a pilot and I can't fly if I'm on anticoagulants. I'm an electrician. I need to climb on, work with heavy electrical wire, and I can't do that if I'm on anticoagulation. It could be, I just don't want to take anticoagulation. I had a relative who died from it. I don't want to take it. It could be the obvious, people with GI bleeding, intracranial bleeding issues in general. But that decision should stem from this shared decision-making interaction using this evidence-based decision aid. And this evidence-based decision aid isn't about Watchman, it's about anticoagulation. So what they're trying to drive, and this is, as you might feel, cumbersome, and it's not easy to necessarily go out and institute, which is why programmatic collaboration is so helpful. But what the FDA and what CMS is wanting us to do is making sure that we've discussed the standard of care, which remains oral anticoagulation, preferably the DOACs, that we've discussed that with patients, and that both parties understand what that patient feels is the limiting factor that would make them not take a DOAC and therefore leave them at residual risk for stroke. And then we can come in and say, all right, this patient has unprotected stroke risk. What can we do non-pharmacologically to help protect them? And so that's what this is really trying to achieve. And then it must be documented in the medical record. This is the other requisite step before, and this is changing. There's some evolution in this, but before the patient is taken for procedure, they are required to have a TEE with these four primary measurements to give us sizing of the atrial appendage. And there's various criteria of how we size it, where we draw the lines, how they're measured. But this is essentially the four primary views that we need. And then this is what the procedure just briefly looks like. It's a single venous access procedure. There's no arterial access required unless anesthesia uses it for monitoring. But from our standpoint as a proceduralist, it's a single venous access. So it's relatively safe. All the issues with arterial access do not exist with venous access. So to some degree, things that would cause vascular injury to the arterial system, MI, stroke related to debris, all those things are not factors in this setup. It's done under TEE guidance with cine fluoroscopy. Requires transseptal puncture with some slight modification of the standard technique, but more or less the standard. And the TEE, in addition to the screening, is also performed in the room right before the procedure is done to screen for thrombus. If there is thrombus in the appendage, then obviously we stop. We don't want to be introducing catheters into that appendage and stirring that thrombus up. Because of TEE and the potential for discomfort, it's done under general anesthesia. It takes about 30 minutes to an hour to do. It's not a very lengthy procedure. It's straight in with the catheter. You're not doing anything else. There's no diagnostic evaluation at this point. It's direct implantation of this device. So what does this look like? So I figured I'd show you what the process would be with some simple schematics. Again, single venous access. We go up through the venous system, approach the fossa ovalis, which is portion in the atrial septum with an area of soft, thin tissue. The process for transeptal puncture is fairly standardized. Currently, it's done under TEE guidance. And in that setting, it's actually an incredibly safe procedure because you can see your needle or your electrical needle, which many of us use now to, or not electrical, but radio frequency needle, which many of us use to cross the septum. You can see it in orthogonal planes and multiple planes and really know exactly where you are. In the first procedures that were performed in PROTECT AF, transesophageal echocardiography was not performed. Many of the operators had not been experienced in fluoroscopic guidance even for transeptal puncture. So you can imagine you're in the heart with a big needle trying to cross the septum without training and without visualization. You're going to have a lot more adverse events. So with these modifications, that itself was a huge jump forward. It made things much more visible and much safer. The transeptal puncture site needs to be very specific. It needs to be an inferior and posterior location. The left atrial appendage tends to be an anterior and superior structure. And so if we're trying to approach it using catheters, if we were to access it in that same orientation, we would come up right under it. And there's no way we could travel into it. So using TEE, you can actually get to that position exactly, the inferior and posterior location along the atrial septum, and then cross it under direct visualization, which makes it incredibly safe. Once we're across the septum, this is an 8 French sheath. We then exchange that out for the 14 French guide sheath. The guide sheath is what will allow us to advance the actual device itself, which is housed within a 12 French sheath. The initial step to guiding the catheter to the appendage is led by a pigtail catheter, which is shown here. Again, in the early phases of this procedure, or the early experience, they did not use a pigtail. They navigated with this very stiff 14 French catheter with a single curve. And you can imagine there's a lot of manipulation happening within the left atrium with a very stiff catheter that led to some of the adverse events that we described. But now we use a pigtail. That pigtail allows us to guide our catheter into the left atrial appendage. The 3 markings that are on this catheter denote the sizes or the various sizes of the device that will be advanced through this sheath. This sheath also comes in now 3 different shapes, and there's more coming. So you can tailor the shape to the appendage anatomy and its orientation. We then use contrast injections to identify our appendage ostium. You can see in this image, the left circumflex artery is traveling right about where the ostium tends to be. The goal, of course, is to cover those pectinate muscles, those muscular ridges and grooves that tend to cause clots to be harbored within the appendage. Once we do that, we take out our pigtail catheter. We're comfortable with our position. The guidance catheter is maintained in position, so those markings are held where we'd like to place our device. We then advance the device through that catheter after considerable de-airing and flushing. Air embolus being one of the things obviously we try to avoid in the left atrium pretty fastidiously. The device is then gradually unsheathed and finally placed in the ostium of the appendage. The device can be captured. So if we feel that the device is too deep or too superficial, it can be recaptured fully. It can be recaptured partially. We can take the entire device out after recapture and put in a different device if we feel like one of the sizing needs to be adjusted. And that is done fairly commonly. Again, as I mentioned in the beginning, this device tends to be oversized because we want it to be compressed within that appendage so that it's secure and it's not going to move. And then it has those 10 anchors around it that allow it to stay fixated within the left atrial appendage. We do another shot to make sure there's no leak of contrast around the device. And then there's a little screw-in device that we turn to release it. And once it's released, it's set in place and free. And so that's the implant procedure. This is the guideline recommendation. And this is relatively new from ACC/HA and HRS, which are our 3 primary societies, including the Electrophysiology Society. And it currently has a 2B recommendation. Again, driving home the point that oral anticoagulation is still the primary first option. And for patients who do not tolerate it or who do not want to take it, and therefore who would be left unprotected from stroke risk, we have a good viable option that's been well tested in clinical trials. In all likelihood, this guideline recommendation will advance in the near future with additional data that's coming to a two-way recommendation, but that is obviously yet to be seen. So that's the portion for the Watchman device. Here I just wanted to show briefly, this is our institution's protocol for how we approach patients who are interested in left atrial appendage closure. And that is pathways involving screening imaging with TE or CT, various pathways that lead to the bottom for surgical left atrial appendage excision in patients who, for example, may have residual thrombus that cannot be gotten rid of no matter how long you anticoagulate them. We have a setup where we protect the cerebral vasculature. I go in and place a protection device to protect the cerebral vasculature. The surgeon goes in with a left lateral thoracotomy approach and using TE clips the appendage at its ostium, keeping the clot within, and then removes it. We've had some success using that approach for patients with persistent thrombus. And then for patients who cannot tolerate any anticoagulation at all, the Watchman device requires 45 days. We have a mechanism of funneling these patients to the ASAP-2 trial, which offers the option, randomized option, of placing the Watchman device with antiplatelet therapy and no anticoagulation whatsoever. And this is something that might lead to a new indication in the future, which would open up this option for even more patients who have significant bleeding issues. All right, so I'll move forward to the portion on PFO closure. This is another option for stroke prevention in selected patients. That selected word is the operative word here. It's very important. And what I'm going to tell you here briefly is a story of these 3 trials. This has been studied for decades and has been tried in multiple trials, trying to demonstrate a significant effect for stroke prevention, a reduction in stroke risk. We're going to talk about these 3 trials, respect, reduce, and close. And what I hope to demonstrate is as you go further in time and you closer to present day, you see that these trials have instituted greater and greater specificity of their criteria, both for both treatment arms. And what you see as a result of that is you get a greater reduction in outcome. And so what that speaks to is the importance of selection of patients in order to get the greatest benefit from doing a PFO closure procedure. So we'll start with, this was which I showed in the beginning. The FDA approved this fairly recently after publication of 10-year data, mean follow-up of about 6 years, from the RESPECT trial, which was the flagship trial in this arena, whose initial publications with short-term follow-up didn't demonstrate significance or very robust effects. But when 10-year data was published, they were finally able to show some differences that led to approval. And this is the RESPECT trial in summary. I've listed it out, a variety of factors out here, but a couple things to note. This was a trial, again, this is the long-term follow-up published in 2017. In this trial, the medical therapy arm was not controlled. So patients could be on aspirin, they could be on warfarin, they can be on clopidogrel, or they can be on Agronox. So there was a lot of variability in the medical therapy arm to start with. The device used was the Amplatzer disc device. There are 69 sites. And again, long-term follow-up was about 6 years. And these are patients between the ages of 18 to 60. And then you have some of the criteria listed there. This was the ultimate endpoint, which was a composite endpoint of stroke, non-fatal stroke, which are listed up there. And the only thing that came back significant of these variable outcomes was a difference in non-fatal ischemic stroke. And so this is some of the data here. And what I'd like to show you with this is these are young patients. The average age is about 45, 46 years old. So young patients who had gone through a variety of criteria to identify their strokes as cryptogenic, therefore being candidates for PFO closure. And you can see that the difference in overall numbers are actually very low. And that's because the difference in events were very low, which is why this trial and many of these PFO closure trials have a very hard time demonstrating efficacy because you have to follow them for longer periods of time to show events. These are generally otherwise young, healthy patients. And so it really speaks to that element of trial design. There's a variety of criteria they use to define their strokes. They used the Ascot criteria and the TOAST criteria. And they all sort of give you a slightly different sense of what this trial actually did. But you can see when they compared recurrent ischemic stroke between closure, 500 patients, and medical therapy, also about 500 patients, you ended up with a statistically significant difference with absolute numbers of 18 and 28. So again, just something to see and keep in the back of your minds as we traverse through the subsequent trials that were done in this arena. Again, I'm just showing the small number of events. These are the graphs, the Kaplan-Meier curve showing the hazard ratios. And again, you can see in the PFO closure group, with time, you did get a significant splay in events. Again, very small effect sizes, but statistical significance owing to the time that was that these patients were followed. If you go to recurrent, a slightly different definition, recurrent ischemic stroke of undetermined cause, your effects, the effect becomes greater, and you do have greater significance in the difference between PFO closure and medical therapy. But again, remember that medical therapy in this group was quite variable. And so I wanted to demonstrate that in this forest plot. I've highlighted a couple of important factors with the red arrows there on the side. The first at the very bottom is that patients with who are on antiplatelet therapy tended to do better with PFO closure. Those who are on anticoagulants did equally well in terms of the outcome of ischemic stroke. Patients with atrial septal aneurysm or heavily bowing redundant atrial septum tended to do better with PFO closure, which makes sense. It's essentially an embryologic remnant funneling blood to that foramen ovale. So it would make sense then that more clots would traverse that area as well. So patients who had that feature did better with PFO closure. And then shunt size. Those who had a significant shunt defined by the number of bubbles crossing on echocardiography also did better with PFO closure. And those with smaller shunts, none, trace, or moderate, did about the same with medical therapy. And then the rate of atrial fibrillation was very low. And this is something that our community talks about quite a bit, how much atrial fibrillation results from placement of this device. One might argue in respect, the rates were low. However, the means of monitoring for atrial fibrillation after the procedure were fairly variable and were not sustained in any manner at all. I'll skip this slide for sake of time, but you're talking about a variety of issues with the RESPECT trial, but which really highlights that despite those issues, if you follow these patients long enough, you do get a significant reduction, statistically significant reduction. This is some more of that statistical data. Essentially, if you take the trial as a whole, the number needed to treat to prevent one stroke over 5 years is 42. Not bad, but certainly something that could be improved upon with more selectivity. I'll move here to the REDUCE trial. This was a trial that was started far later, but completed and published ultimately at a similar time frame. This trial took out anticoagulation in the medical arm altogether. So we're becoming a little more specific. It used a couple different devices by the same manufacturer, which were similar in nature, but still different. It had slightly different criteria, but basically more or less the same. But it took out anticoagulation altogether. So patients were either placed on antiplatelet therapy or they were had device placement after going through all the criteria that would make them a candidate for PFO closure. And this is what they found. So again, you see a little more robust of an effect now that we have more specificity. Very low absolute numbers, stroke rates still very low. Again, a very young population. But these patients, again, antiplatelet therapy, and a greater proportion of them, 81% of patients in both arms, had relatively large shunts, as again defined by bubble criteria. So the number needed to treat here was 28. So you see, as we've become more specific, a little more refined, larger shunts compared to antiplatelet therapy alone, you get a better treatment effect with PFO closure. Here's that same data shown on a table. I'll skip through this just for sake of time again. And this is, again, a little forest plot showing the effect of shunt size. So large shunts, significant difference with PFO closure. Small shunt size, that's the one graph that clearly crosses unity, doesn't create much of a difference. And again, this is the atrial fibrillation rate, a little bit higher in this series. And again, likely because they were watching a little more closely. Of note, the vast majority of these atrial fibrillation instances occurred immediately post-procedure or within the first month, and beyond the first month period tended to resolve completely. And were not seen on extended term monitoring. And that's the key in terms of diagnosis of atrial fibrillation is, are these patients actually being monitored, or are these instances that are being seen sporadically on single EKGs? But something important to note, because obviously from what we've seen, what we know, atrial fibrillation would require anticoagulation. And one of the premises of treating patients with PFO closure is that they don't require anticoagulation for other reasons. And if they did, the outcomes are very similar. So this is something that we still need to keep in the back of our minds. And then this is the last or most recent study, the closed study. And in this study, they had 3 groups. They assigned a device closure group, they had an antiplatelet group, and they had an anticoagulant group. So even more specificity and definition up front to try to clarify this issue of what happens to patients who can be on anticoagulants. One of the issues with this study, I should mention, is there were more devices, the types of devices, all of which are very, very similar. They're all clamshell devices implanted in left atrial, by right to left atrial crossing, but more a variety of devices in this study. So what do we see here? So in this trial, you see in the closure group, again, much more selected group, no events whatsoever, no strokes. Whereas in the control group, and there were 2 groups in the control arm, antiplatelets and anticoagulants, there were still low numbers of strokes, 14 events, but 0 to 14 is a fairly difficult comparison. And in this trial, so because of that, you get this almost ridiculous looking relative risk reduction of 97%, but it comes from the fact that there were no events in a very carefully selected device group. Number needed to treat for this was 16. And I'll just go here again. This is just laying out some of the numbers on a table. I know it might be hard to see, but if you look closely and you look at the comparisons they made, so the set on the left is comparison between PFO closure and antiplatelet therapy. On the right is anticoagulant therapy versus antiplatelet therapy. They did not directly compare anticoagulants to PFO closure. But if you look at the absolute numbers, you have 0 out of 217 patients had strokes with PFO closure. And if you look at the anticoagulant group, you had 2 out of 143. And this is the per protocol analysis. If you go by the intention to treat, it's 0 versus 3. So numbers that would likely not give you statistical significance if they were compared. And again, what this tells us is our patients that are being considered for this therapy need to be screened aggressively for other causes of other indications for anticoagulation. And those are the patients who might just do as well with anticoagulation. And the patients that do not have other indications would be served well with PFO closure as compared to antiplatelet therapy on its own. And so that's what I draw from these 3 trials going forward over time. You increase specificity, you have tighter selection criteria, you're picking large shunt patients with large shunts who do not require anticoagulation, who have high-risk features such as atrial septal aneurysm. Those are the patients we can anticipate are likely to have the most robust treatment effect from PFO closure over time. And remember, one of the things that we don't look at, but is very important in this population, is that these are young patients, some of whom are in their 20s, 30s, 40s. For them, even though it might take a while to accrue sufficient risk or build comorbidity to build risk for future stroke, a stroke in a young patient has potentially a lifetime of impact, leading from disability to loss of work hours, employment, all sorts of things. So stroke prevention in this group, despite the small treatment effect, is not trivial. It is important. It's just doubly important that these patients are selected carefully so we know that they're going to accrue the most benefit. This is the atrial fibrillation rate. And again, you can see of those 238 patients in the PFO closure group, 11 had atrial fibrillation. And again, these are all noted within 30 days and then were not seen to recur with long-term follow-up. Again, there's some variability in what that long-term follow-up is. Some were implanted follow-up monitoring devices, some were just patch-type devices, and some were serial EKGs. So there's some variability in that. Tighter follow-up than was done with respect. And again, a relatively small number, but still something worth noting because in the back of our mind, AFib screening is a significant part of selecting patients for PFO closure. So as we get further data, it's something that we always look for when screening these patients. This is our protocol at our institution, starting with the initial index event, which is often where you guys are acutely involved in dealing with the stroke as it's happening and in resolution of the acute event. And then we go further down through our pathway, looking at a variety of features that are going to rule out other indications for anticoagulation or other therapies. Vascular disease, DVTs, hypercoagulable states, atrial fibrillation, and if all of those are negative, then these patients meet indication for PFO closure. And then I'll skip through this. These are just 3 different categories that we often place these patients in for obvious closure after a neurocardiac discussion, no closure because they've met criteria for other therapy, or closure requires some multidisciplinary discussion. The group that has been coming up most often in my practice has been the patients over the age of 60. In their approval, most insurance companies wrote that these are patients predominantly within the age groups of 18 and 60. They did not exclude formally the patients over the age of 60, but that's a question that commonly comes up. If you have a patient who's, acts like he's 40, but he's age 62, is that a person you should exclude from PFO therapy? And I would argue not, but that often stems from a discussion with our neurocardiology, with our partners in neurology to come up with a final decision, which is very, very helpful. These are the 2 devices, and I'll skip over this, but there's the Amplatzer device and the Gore device, very similar, slightly different anatomic design, slightly different conformation to the anatomies depending on the patient themselves. And then this is the procedure itself. Again, moderate conscious sedation, fluoroscopy, and ICE. ICE is intracardiac echo. We do not require intubation, does not require TEE. The sheath itself is a 10 to 12 French sheath. The ICE catheter can be 8 to 10 French. There is manipulation within the left atrium. Obviously, we don't have to cross since there's already a gap. But air embolus is our enemy, and that's the thing we screen for and work on most closely to try to avoid. And same-day discharge is possible. And then this is my last slide, which is we have all this data, we have all these recommendations, but as I mentioned in the beginning, the guideline recommendations from our societies still don't often coincide with that flow or that pattern. And so as far as guidelines go for PFO closure, it's widely done. We don't have numbers because of the 2 different device companies, but anywhere from 17 to 20,000 procedures potentially done last year, but without a formal guideline recommendation from our societies. So this kind of paints an interesting picture of how this field of neurocardiac devices has come from clinical trials through the FDA to approval, how it's being instituted, and some of the things that we as providers need to pay attention to, particularly patient selection, keeping the patient involved in how we determine who gets to have device therapy versus not. And that's my last slide. Thank you very much for listening. Thank you very much for inviting me to share this with you. And then certainly any questions, I'd be happy to answer.
Thanks. Fantastic talk. So let's first start with PFO. We've gotten several questions on PFO. The first one is, how long would you monitor for atrial fibrillation prior to recommending PFO closure?
This is a great question. So this is something that's been debated extensively in our community amongst cardiologists and neurologists. It ranges anywhere from 2 weeks, which is often the standard duration for a lot of the patch type monitors, out to some people going 6 months or longer. Certainly with implantable devices. Certainly that question, the answer depends on a little bit on who you ask and what they're invested in. Obviously the implantable monitoring devices, those companies will say, well, the longer you monitor, the more sure you can be, the more your detection rate, but there's got to be a limit to how long you go. And then a lot of the other companies with patch type devices will tell you, well, our devices have better fidelity, we have better algorithms, you don't need to monitor that long, you can come up with a decision in 2 to 4 weeks. At our institution, we initially started with at least 2 weeks. We've more recently gone preferably to a month. But if you ask different institutions, you will get different results. Many places will go out to 3 months with implantable devices as well.
Okay, great. What about, would you treat a small PFO with a septal excursion of less than 10 millimeters if that is thought to be the cause of a stroke?
So what I'll often do in that setting, and that's describing some of the anatomic features, which are very important. So the atrial septal aneurysm, usually we refer to elevation above the plane or below the plane of about 10 millimeters to call it aneurysmal. For those patients, I would use shunt size. And shunt size, again, in all of these trials was defined on bubble crossing. If there's any ambiguity with transthoracic or TTE, then we would use a TEE to characterize the number of bubbles that actually cross. The fidelity of that image is much better. You can clearly see the bubbles crossing, and you can do that with the Valsalva. So with compression of the abdominal, of the thorax, you can enhance the amount of pressure that would force bubbles across to see if there's bubbles crossing more so with Valsalva than without. So you'd use all features. You'd use all three of those features. One thing that's very important, the characterization of small should not be based on two-dimensional imaging of any kind, whether that's TTE or TEE. And that's because what you're looking at is a flap, and the two-dimensional image cuts across that flap. So you might cut across the very edge of that flap and get a small degree of excursion. You might cut across the middle of that flap and get a big excursion, visible lifting of the flap along the atrial septum. So looking at it from any two-dimensional view, if you see a very small elevation of that flap, but you see a huge number of bubbles crossing, it may be that you're just not catching the point of greatest excursion of that flap. And so that's where that definition becomes very important in the selection process. Other features that are used as well are intracranial imaging features. So patients who are young with multiple emboli or multiple infarcts, punctate infarcts, lacunar infarcts, with a large shunt, those are certainly patients who you might choose to close even with a visibly small defect.
Would a Chiari network increase the risk of stroke or paradoxical embolism for patients with PFOs?
That's a great question. So, sometimes you'll see some very interesting things on transesophageal echo. Remember, our bodies were built in embryo or in utero to facilitate blood flow to this area. And so there are some Chiari networks that will literally, they almost act like water slides at a water park, where they're literally pushing blood right to that defect. You don't see that often, but it serves to reason that if you had that along with an atrial septal aneurysm and a significant excursion of the defect itself, there's a greater likelihood of blood being shunted across there. It's thought that, not demonstrated in clinical trials, but it's thought that in patients who have continuous bubble crossing with each heartbeat, or anytime you inject bubbles without Valsalva, that they likely have some right atrial anatomic features that are funneling blood directly towards that PFO. And a Chiari network is one of those features.
Is there any indication for a short course of anticoagulation following a PFO closure?
That's a great question. So one of the things that we would like to do is, and this has been done in single center small studies in Europe, but it's never been done on a larger scale with high fidelity monitoring. The reason we ask that question as well, if there's AFib happening immediately afterwards, why not just treat these patients with anticoagulants and you're protected? And then if you have resolution of AFib later on, you could potentially take them off anticoagulation. Very similar to what's done after bypass surgery. So about 40% of patients after coronary artery bypass surgery will have AFib. Vast majority of those patients we put on short-term anticoagulation and then stop later after a period of monitoring. So we could take a similar approach and do that. We just don't have trial data to demonstrate that. I think it's a very good approach. I've done it in several patients who have had AFib occurrences, especially because these patients tend to be younger and they tend to be able to tolerate anticoagulation fairly well. But it's something that we've discussed amongst our group and others as well of should we be testing this prospectively.
Let's just switch topics just for a few brief moments in terms of Watchman. One of our viewers asked, what is the reimbursement for the Watchman device?
So, it depends. I don't have an exact number for you now, but the answer to that question depends on where you do it and how much investment is done beforehand. So for example, if you're using a cath lab versus an EP suite or a hybrid operative room suite. If you're doing TEE monitoring in a outpatient setting versus in an in-hospital setting, because for the most part, TEE screening is done before the device implant. The same goes for if you're using CT scanning. So a lot of institutions are using CT screening because it's cheaper than bringing them in for a TEE and engaging a procedure, requiring anesthesia, requiring a cardiologist, et cetera. So a lot of the costs from a programmatic standpoint, if we're trying to optimize cost and the effect of our reimbursement, comes upfront in the screening, in the processes that are involved. So in our program, for example, our workup, or one of the targets of our workup, is to do the entire thing in a single day with multiple clinic visits with different operators. And our goal is we don't have this yet, but to have that screening imaging done by CT in that same day as well. And the purpose of that is exactly the endpoint of this question is how can we make it effective and attractive to our administrators for financial stability in the future.
Let's just ask one question on left atrial appendage closures. Would you recommend it if someone's had a stroke several months or years after they've had the closure, if no clot is seen on the TEE and no other cause of stroke could be found? And can this device specifically be removed at a later time if there's no need for long-term anticoagulation?
This is regarding the Watchman device?
Yes.
Yes. So the Watchman device, while it's often the patients that are referred are patients who have had stroke, stroke is not a formal indication for the device. So it could be the only indication that's required is atrial fibrillation with the CHA2DS2-VASc score equal to or greater than 3. So patients who come into the office, maybe they've had a stroke years ago, maybe they've never had a stroke or never had any events whatsoever. Maybe they're completely asymptomatic from their AFib, but they've got comorbidities that give them an elevated CHA2DS2-VASc score. Those patients can come in and say, hey, I don't feel this. I don't know why I have to be on an anticoagulant. I bruise every time I fall. I bleed when I go to the dentist. I'm tired of it. That patient would be justified going through the process to get a Watchman device. So it doesn't have any direct relation to stroke itself. And then once placed, it cannot be removed. The expectation and what we hope is that after 45 days, the device has been endothelialized. So your bloodstream never sees that appendage cavity ever again. It's covered by this endothelial surface. The device supplies the scaffolding for that endothelial surface to take root. And it's as if the appendage has been cut off.
We have several questions remaining, but maybe you could answer one last one in the 2 minutes that we have. Is there any sensitivity difference between CT chest-gated and TEE to look for PFO and an intracardiac thrombus?
Yes, so CT is a little challenging. So that what were the two modalities? CT and what else?
CT and TEE.
Oh, TEE. Yeah, the benefit of TEE is it gives you live imaging. Whereas CT is essentially using a variety of cuts to create a cartoon image. So yes, you can see PFO on CT, but it depends on whether the hemodynamic circumstances will allow that PFO flap to elevate. So unlike an ASD, which is a hole, which you can see perfectly fine on CT, because that hole is present throughout the cardiac cycle, a PFO flap will often lay flat and then elevate as pressures during the cardiac cycle fluctuate. So if you don't catch it during that elevation, you might not anatomically actually see the PFO gap itself. You might see it if it's there, and you might see shunting of contrast across it, but you might not catch it. So the sensitivity for that reason is lower on CT for PFO. TE gives you real-time imaging. It allows you to see bubble crossing. It allows you to potentially or potentiate bubble crossing with Valsalva. So if there's any question, TE remains the gold standard for that purpose.
Could you consider a TCD with bubble in that case then?
Yeah. So that's actually been done quite a bit historically, but it's not. I've talked about this with our neurologists. It's not done that commonly anymore for reasons I'm not entirely sure of. But yes, that has been used historically, and it's actually a fairly sensitive modality for detecting bubbles crossing that you could then correlate to a PFO.